Dr. Diana Londoño is one of only 10% of urologists in the United States who's a woman, and only one of only 0.5%, that's half of 1%, who is a woman and Latina. Dr. Londoño earned her MD at the David Geffen School of Medicine at UCLA and completed her urology residency at Kaiser Permanente in Los Angeles. She's now a board-certified urology physician, not a provider, and we'll talk a little bit about what that means a little bit later, at the City of Hope in Glendora, California, and podcaster and the founder of physiciancoachsupport.com. Now, Dr. Londoño is a little bit on the humble side, so I had to dig a little bit deeper to find out that she's also the recipient of 5 stars on healthgrades.com, U.S. News and World Report magazine, and listed in Super Doctors 3 years in a row. Welcome, Dr. Londoño. Thank you so much for joining me.
Thank you. The pleasure is absolutely mine. That is such a kind introduction. I really appreciate just being here, hopefully sharing some things that can be helpful for the audience, that I do think, you and I think it's important that we know about some of these pearls. And yeah, just sharing a good conversation that can hopefully get you into taking that different step, an action into something, and maybe just with a little knowledge, just give you that extra, empowerment to take care of yourself and your health.
Exactly. Well, first, I want to talk a little bit about #NotAProvider. Can you explain what this means and why it's important?
Yeah, this is something that has sort of become, commonplace that we use indiscriminately, the word provider. And, it'll be from colleagues that are physicians, from administrators that say, oh, this is your provider. And it's really coming actually from a place of love, loving our profession, our role. It is temporary, but our role as physicians. Physician is a word that has been around for, thousands of years, since like the Greeks and way back then. And the definition of physician is a healer and a teacher. And I really think that role of where we teach patients about their disease, about what to expect, about what their body is, about medications and why they're taking it, what are they for, is really important. It's not only to diagnose or to do surgeries, but it's really to teach. And that's really important. And as a healer, we are there, as surgeons, we like to do a lot of stuff. Take this out, take that out, fix it, surgical. A lot of stuff that we can do, even as surgeons, is healing by being present and not doing, but just being there for the patient, to listen to their fears, listen to their, anxiety about anything that they're there for. Because every patient truly, and I'm a patient myself, we all have a fear. We're a fear. What does this mean for my life? What does it mean about this medication side effect? What does it mean of how much time I need off for work? There's so many fears. And when you address that fear, things are very different than when you just kind of skim and gloss over it. So again, we are healers as our role is defining us, and we are teachers. And provider gets really murky, because then you put nurse practitioners, we put, really like nurses sometimes, and physicians into one. And then so you go to see what you think is a physician, and you don't know if they're a physician, you don't know if they're a nurse practitioner, and it gets cloudy. There is a role for everybody in medicine, but it just has to be defined who's taking care of you. Just like if you want to know, is it the resident taking care of me, or is it the attending? There's different questions you're going to have, and they have different knowledge. And so you just have to be transparent about it. But honestly, what happens is this is a great place, because nurse practitioners and PAs are like half of what you would pay a physician. So it's cheaper for the systems. And unfortunately, sometimes they do tend to, and studies have shown this, it's not just my opinion, studies have shown that they tend to order a lot more tests, and because they don't know as much of what is presenting, so they'll order all these expensive tests, and then that actually in some way goes back to the facility, right? Like that facility fee goes back to the hospital, and it's
profits from those tests and interventions. Some of those tests are not the word I'm looking for. They're not simple, just blood work. Sometimes
They're
they're
expensive
very
CT scans,
invasive.
MRIs.
Exactly. Not only are they expensive baseline, but some of them are invasive.
Invasive, absolutely.
Exactly.
Absolutely. And painful. I mean, like even
Yeah.
just the IV, who wants to get an IV for a CT that you maybe didn't need? And then once you get that CT, what are you going to do with that information? We want to know if you're doing a test, why are you doing it? What are you looking for? You know, it's not just like shotgun, let's see what shows up. It's like, what are you looking for so you can do that test? And then what are you going to do with the results? So again, there is a reason why this is all getting murky, but it's really a love again for our profession to really define our role. And again, it's just a role. It's not from the ego of like we are better, we are higher. No, but just make things clear for the patient so they know what's happening. And so this is why it's important not a provider. And also it has really dark roots. I mean, it was used in the 1940s by the Nazis to really demean and dehumanize the physicians, who were Jewish. And it was another way to psychologically, really diminish their role. And so it was used during that time for that. And then I just don't want to be involved in anything that says, or is involved in dehumanizing another person in any shape, way, or form, even if it was in the past. I just don't want to be involved in that. Even if I'm not Jewish, I'm just human. And I don't think that's a way to lead. I want to lead with love, not with hate, not with demeaning people. So that's really why I'm passionate about it. And I wrote an article on Kevin T that was pretty popular, shared about, I'm a physician, not a provider. I sit on our website, Physician Code Support, that you alluded to, which I founded for physician support, which is confidential, one-on-one peer-led. There's a whole section about all these articles about the word provider, from ACGME, from Kaiser that has banned it. The Washington Medical Association has just recently also banned it. And so there's a lot of information of physicians, organizations saying like, this is not a humane way to speak about or give a title to physicians. And you can also get a badge. I mean, I have a badge that says not a provider because I'm not a provider. I am a physician. Just really to get the conversation started, really to bring awareness about what this word is about, and really try to change, this whole system and make it a more humane, a more honorable way to lead. And again, because of the history, because it takes away our ability to come as healers and teachers.
There's something that you said, Dr. Londoño, that I think is really important. You said, I talk about the word provider and that I'm a physician and not a provider. And there's a difference, not because of ego, but because of love. And you said for love for the profession, but knowing your work and your platform and all the work that you've done and you're doing, I know that it's for love of humanity, love for patients. Because what happens is when you say we're providers and you encompass all comers, physicians and physicians extenders under that one umbrella of the word provider, patients get confused. Absolutely. And you said it gets murky, and that is done on purpose sometimes. Mm-hmm. And why? You have to ask the question why. At the end of the day, I always say follow the money.
Oh yes. Oh my God.
You have to ask why. Money. Follow the money.
Money. It's money. Absolutely. I mean, and I alluded to the beginning. Again, it is cheaper to have a nurse practitioner pay us half the salary that would you pay a physician. So it's like fantastic. And then they order so much that goes back to the hospital, which if you get a CT scan at a imaging center, outpatient standalone versus a hospital setting, I mean, it's really like probably 4 or 5 times much more money. So imagine like that system is creating its own referral and money. And so it's like, of course, it makes absolutely business sense, but it doesn't make sense for a patient. It doesn't make sense for like, what are you looking for? What are you doing? And like, you're doing invasive stuff, like you said, that's not kind. That is not loving. That is not necessary. And the burden that you put on people spending so much money on unnecessary tests, like we have to think about that. People are not doing well financially from pandemic and from a lot of things. Many lost their jobs, their businesses, and now we're putting another strain. And then they trust us because they think, well, this provider is telling me I need this test, so I'm gonna get it done. But sometimes I wonder, like, did you really need that? And I'm not saying this for everybody, but I just have seen that pattern, and I have seen that, like, I'm like, why are you ordering that? It doesn't even make sense. And once you order it, like, then what are you doing with that information? Because then I see that it just gets turfed to all the specialists. Oh, it said one thing about the liver. It said one thing about the kidney. And these are benign things that you would never refer out, but they didn't know that. And they just refer. And again, it gives more referrals, more visits, and it's just really burdening the system. But yeah, this is like the badges you can get. It says not a provider, and there's another one that says physician, not a provider. But yeah, it's just really start a conversation and really start having mindfulness, awareness of like, why are we doing things? Why don't we do things? And like, what if we could lead a different way? What if we could have compassionate leadership, compassion in every interaction we have? I mean, like, what if? Let's just think of a world where it's different. Just like Gandhi said, be the change you want to see. Let's just be that first, and then it will ripple its effect.
Exactly. Well said. The other thing I think about with providers, and as you mentioned, with physician extenders, is what we're really talking about. The nurse practitioners and physician assistants. And now I think there's a campaign for physicians to be called physician associates, but we're talking about physician extenders. And the move by the U.S. for-profit healthcare system to put us all under the umbrella of providers, physicians, and physicians extenders. You brought this up, and this is really important. I want to stress again, is the point that if you're doing a lot of tests, and you're doing tests because you haven't been trained as a physician extender to necessarily know where something is going, and you might not have been trained, it takes some experience and training to be able to figure out, is this test going to change what we're going to do? Absolutely. And I find that that's where the over-testing, we call over-testing, comes in. And so first thing I want to point out, if the test is going to change what you do, absolutely. But ask the question. If a nurse practitioner or PA or physician extender, physician's associate says, you know what, let's do these tests, A, B, C, and D, 1, 2, 3. Okay, so how will that change what I decide to do? How will that change things? How will that change what is necessary, or how will that give us more information? Will it change the treatment? Will it change what happens to me? So that's the first thing. The other thing is, bringing up and talking about, you brought this up, the money. So when we do lots of tests, even when we have insurance, it's not protecting us from being, frankly, bankrupt and in having a lifetime of debt from medical issues. Why is that? Because insurance does more and more co-shares or co-pays or co-insurance, meaning patient cost sharing. As we go further along, it's more, every year we're going to have more and more cost sharing. For the for-profit insurance companies to stay profitable, they're going to have to put more of the cost, percentage of the cost, on the patient, right?
Yes,
okay. Absolutely. So we're doing all these tests, and if I have insurance, but my insurance requires that I pay 20% of everything, that adds up fast. If I have what's called 80-20% co-insurance, let's say, 80% of everything that the insurance decides they think is medically necessary, not everything, that's an important point, but what they think is medically necessary is paid for by them, but you're on the hook for the other 20%.
Absolutely.
And if the average CT scan by a facility, and I would say, if you want to do the most expensive care, not necessarily the best, but if you want to pay the most, go to something affiliated at the hospital with a hospital system or medical care system. So the care test gets referred to the medical care system, the hospital facility system, and you have, it adds up. Let's say $5,000 for a CT scan. Let's just make the math simple. It's actually, I've seen bills for $5,000 for a simple CT scan where we're looking for stones or we're concerned about kidney stones. Let's say that, just to keep the math simple, let's say it's only $1,000, which it isn't if you go to a hospital. It's going to be about $5,000. But okay, let's just say $1,000. So if your insurance says, okay, will cover it. They're only going to cover if you have 20% coinsurance, which is
$200
really common.
adds
That
up.
is $200. That adds up.
Absolutely.
Adds up.
Yeah, I
So-
mean, when I was in Miami and I had a thyroiditis, an inflammation of my thyroid, I had this special scan called nuclear scan on my thyroid. It was $10,000 for that test, 10,000, and then I had to pay, I think, about $1,000, and I had, good insurance was called that.
Right.
And I had a small heart attack. I mean, I'm like, how can I pay $1,000 for this test? This is just absolutely insane. And I'm a physician at the facility, and I actually fought it. I'm like, no way. I mean, I work here and this is crazy, and it got reduced. But even then, I mean, $1,000 for one test, which this one was necessary and everything, but that adds up. It's a lot of money. So again, when we're adding all these things, and not just imaging, I mean, even blood tests, some insurances only pay for some things once a year. You can't keep getting, like, for example, for prostate cancer screening, that PSA test, prostate specific antigen, it's once a year. If you keep getting it multiple times a year, it's not going to be covered in some insurances. So you have to be aware of that. And, just again, why are we doing all this stuff? Like, what is the reason? We got to ask why things are happening. And it's important to ask. It's not being defined. It's just being informed. Like, what are we doing this for? And it's not about being defined. And again, somebody that comes in with an ego, again, the ego comes back again. Oh, you get reactive and defensive. No, just I want to learn. We all have to bring down that ego and be teachers.
That's right.
Say, okay, this is what it's for, without being offended. Like, why are you questioning me? No, we gotta explain, this is why I'm doing this, with a kind and loving manner. Again, we gotta lead from love and explain, why do we want to do this? What is it gonna show us? What is it gonna change our management? Because you're correct. I can do a lot of stuff all day, but it doesn't change what is going to happen. So I'm not going to do it. I'm not going to order these tests. I'm not going to make you come back from invasive testing. That won't change the management. Yeah, I can do it academically to think about it. Maybe like you're doing some research. But if you're not doing that, many tests don't need to be done, but they generate revenue, and like, it is a business. Let's just be clear about the business of medicine and the healing and the actual things that are indicated. And like, yeah, that's gonna be very controversial. People are not gonna like what I'm saying, and that's okay. Those are their opinions. But let's just really be kind of transparent, truthful, and just be a little bit honest about the whole picture that people don't want to talk about.
Let's be transparent. One thing that you talked about, that you mentioned in passing, that's really important, as you said, I fought it. I fought that bill. And many people don't know that all medical bills are negotiable. Why? Because it's a made up number. The retail, I call it the MRSP, the manufacturer retail sticker price of the retailer, in this case, the hospital or medical care system. They make up these numbers. These are totally made up numbers so they can negotiate with the for-profit insurance companies that run the U.S. healthcare system. That's it. They're made up. So I tell people, look, there's only one right way to pay a medical bill. And the first step is making sure that you call the provider's provider, meaning the hospital system. And I use the word provider, and this is important in this case, is because I come from many years in the U.S. healthcare insurance industry. And the term provider is used for physicians, not nurse practitioners, and physician assistants, not physician extenders, but physicians and facilities.
Right.
So they use that encompassing word. When I use the word provider, I'm usually always talking about medical care systems and hospitals. When I mean provider, I mean the system, large systems, or it may be a very large hospital. When I say provider, I'm never referring to physicians. So I just want to point that out. So anyway, when you get a bill, because every bill is negotiable, because all of these services in the United States are just the numbers for the retailer, in this case, a hospital system, charges for them is totally made up.
Yeah, because the same test in different hospitals is going to have like completely made up numbers that are different.
Exactly.
So how can that be? Like, that's why there's all this movement to transparency. Like, how can one hospital setting be $4,000 and the other one's $2,400, and you go to the ER and one saline bag is $2,000. I mean, literally, and then the other one's $400. So these numbers are totally made up.
This is random. Exactly. So thank you for bringing these issues up and clarifying this. And it forces me also to clarify. I often talk about providers, and I want to tell our audience, our listeners, tell everyone, when Dr. Vergy and Dr. Londoño is saying providers, we're talking about hospitals and medical care systems, not physicians. If I'm talking about the actual physician, the actual healer and teacher of medicine and healthcare, I say physician. Just to be clear, because I come from the background of what do you refer to the administrators of medical services, and those are hospitals, healthcare systems, so we call them providers. So I just wanted to clarify that. So thank you for teaching us, Dr. Londoño, of the difference between physicians and providers in the history. So I really appreciate that. So also, as a primary care physician, there are a few things that I wish people knew about protecting themselves from urological problems like kidney stones, repeated urinary tract infections, an important one, screening for prostate cancer. Can we talk a little bit about these issues?
Absolutely. I mean, I think these are really important, and they, probably urinary tract infections are probably the biggest burden, I think, honestly, for, healthcare and visits to urgent care, and just really draining the system, and also leading to antibiotic resistance. So many people get treated for presumed infections and they don't have it. And so I'm going to step back a little bit and talk about something called asymptomatic bacteria, which is a fancy name to say you have bacteria in the urine, but you don't have symptoms. And this is very, very common, especially after menopause. So after you no longer have a period for a year, you're in menopause. And if we check everyone's urine at that stage onwards, many women will have bacteria in the urine, but they don't have an infection, and it's different. An infection means you have symptoms of it, which would be pain when you pee, urgency, you have to go right away, frequency, you have to go many times, and again, it hurts. And sometimes it could be blood, not always, but it could. And then you check a urine sample with a culture, and the culture shows there's bacteria. 100,000 colonies is what is, said as a culture that's positive. So if you have both of those things, then yes, you have an infection, a UTI, and that needs to be treated, because otherwise your symptoms won't get better and you're not going to feel well. So that is an infection. But I see so many women that come to me and tell me, oh yeah, my doctor called me and told me I had an infection, and then they gave me antibiotics. And I'm like, well, what were your symptoms? And she's like, none. They just checked the urine, maybe for their yearly physical or something. So that's not an infection. That is asymptomatic bacteria that never has to be treated ever, unless you're pregnant, because it can affect the baby, or unless you're going to have a surgical procedure, especially urological, but sometimes other ones like orthopedic procedures, sometimes they want that to be cleared out because they can go into any hardware that implant. But apart from that, you leave that alone. You never have to treat it. Nothing's going to happen to you. Like you just, we all have bacteria in our skin. And if we swabbed our skin, it would be full of bacteria, but we're not, disinfecting and sterilizing our skin. It's the same thing with our bladder bacteria. Just leave it alone. So that's number one. Like if somebody tells you you have an infection, like nobody can tell you that. You have to tell the physician that you have symptoms of it, and then it gets checked. Also, please always, and you kind of have to ask that a urine analysis and culture gets sent out, because if you don't have a culture, you don't know which antibiotic could work, if it was a correct one, if it was resistant, and then maybe symptoms will go away because it's not the correct one. So that's really important. And the most important way to prevent infections, especially for postmenopausal women, is to put estrogen back into the tissues. I'm not talking about systemic estrogen. I'm talking about with menopause, you lose all of your estrogen. You don't produce anymore. So you feel dryness in your face, your hands, also your vagina. But because it's not being used for perhaps sex or babies at that point, we just neglect it. We just don't look under the hood. It's like some shameful place that is dark and nobody can look under. But it's really important because it's gonna feel dry, just like if you don't put lotion in your hands, it feels crackly and uncomfortable. The same thing feels there when you're just even sitting down. And then that puts you at risk for infections. So a pea-sized amount of estrogen cream around where you pee the urethra and the vagina is life-changing. You're going to feel better. It's very, very, very safe. It's not absorbed into your system, your breast, your uterus, your ovaries. So it's really important that you use it. And really every woman should really be on it because it's very safe and it's needed to prevent infections, to prevent pain. Many times women will say it hurts when I pee, but it's not the actual urine or urethra or bladder. It's when the urine that is acidic touches the tissues outside. So it's almost like if you put lemon into a cut, it's gonna burn. So the burning is not because of the urine being an issue, it's touching that dry tissue. So it's really important that you use that daily, just like you use your face cream. You gotta put the cream around the urethra where you pee out of. So that's the number one way to prevent them. And of course, there's other, anatomical things we can think about. And sometimes, yes, if there's kidney stones, that could be a nidus, like for infections, and there's other things, or as you're younger, related to sex, or different things. But the majority of these recurrent infections are really in post-menopausal women, and they can be easily treated safely and prevented. So estrogen cream is really important. Please use it deliberately. It's safe. If people keep getting antibiotics, it's time to really see a urologist. Don't wait for the 5th round of antibiotics. That's, a disservice to them. And if they don't have symptoms and your culture shows bacteria, leave them alone. I promise, it's okay. Do not treat them with antibiotics that they do not need, because it's creating resistance and it's creating side effects and allergies and problems that they didn't need. So, and then they get a yeast infection because you wiped out all their flora out. Then they get a painful yeast infection. They get intestinal infections like Clostridium difficile, a very severe infection. Like, they just feel awful. If you don't need antibiotics, don't take them. If you do need them, they're very important, but many times they're just really overused.
So if you're a post-menopausal woman with recurrent urinary tract infections, recurrent bladder infections, talk with your physician, your gynecologist about estrogen cream that you use in the perineal area around the urethra, around the vagina, in that area. Also, if you're postmenopausal because you had a hysterectomy, a complete hysterectomy, including your ovaries removed because of hormone-related cancers in your past, definitely talk with your oncologist and your physician before you talk about, okay, I really want to use estrogen cream for this issue. You may be able to, but talk with your oncologist and your physician about it before.
Yeah, and it's actually very safe. I mean, I work in a cancer center. People are always concerned, but the ACOG, the Academy of Cancer, they actually support the use of it. And again, it is not systemic. It is topical.
The absorption is not going to be systemic.
It's not systemic.
You're not going to absorb enough systemically, meaning to get into the bloodstream to get through your whole body.
Yeah,
and that's why you want to have discussions with your physician.
Correct. 1 year's worth of estrogen cream by the urethra is equal to 1 pill systemic. So it's really low. And many times the quality of life is so important. I mean, we could be cancer free, but our quality of life is so terrible because we're getting pain and infections.
Yes.
But it really is worth it to get them out of the hospital, get them out of getting severe infections and being hospitalized for infection from the urine, from the dryness, than it is to, do the cream. So again, and there's also non-hormonal things you can do for dryness. So you can talk to a urologist, a gynecologist about it, but you got to start something to moisturize the area. Otherwise, it's going to be always continue to occur.
Yes. Thank you so much for that important point. That's a big deal. That's very helpful. Thank you. Also talking about prevention of or protection from getting kidney stones. So I'm hearing stories about people who are trying to do a high protein diet, right? No carbs, low carbs. So they're trying to say, okay, I even talk to people who are preppers who want to be able to live off the earth, off the, not the earth, in the wilderness, I should say, in nature. If something jumps off, Mad Max, Armageddon kind of thing. So they pack, dried beef jerky, dried turkey jerky, and all these high protein things, and cut out carbs, and don't realize that even if you have a normal system, that's something that could increase your risk for kidney stones. Can you talk a little bit about kidney stones and protecting ourselves from kidney stones?
Yeah, kidney stones are extremely common for both men and women, and they definitely give us job security because there's so many of them. So, I mean, they're
Yeah.
just very, very common. And if you have a kidney stone and you don't address why you made it, you have a very high chance that 50% chance you'll get another stone within the next, 3 4 years. So it's very high chance of recurrence if we don't do prevention. So prevention is key. I mean, yes, I can take them out, but I spend a lot of time talking about prevention. And so if you pass the stone and they analyze it, then you'll know what the mineral is made up of the stone. Just like if there's emeralds and rubies and diamonds, the stones are made of different minerals. And that can give you a clue of why they're made. And then there's also some tests you can do in the blood and a 24-hour urine collection to give you some ideas about the diet or the fluids that is causing them. But really the main cause, well, one of the main causes is not enough water. Dilution is a solution. So if you dilute out and you drink a lot of water, it's going to dilute out anything that could be saturated in the urine causing kidney stones. So what can saturate, what can be elevated and cause this problem? It's actually a problem of both acidity and it's a problem of too much like calcium or salt, and I'll explain that. But when you're talking about the meat and things like that, yes, meat, red meat especially, creates an acidic state because it has urea and ammonia. That's going to create that acidic state, which is a perfect place for stones to be made. So red meat is very acidic and it's going to make those changes. Salty food, like if you talk about like the beef jerkies or cured meats, any cured meat, salamis, even the turkeys, they're very salty. So salt gets exchanged for calcium in the urine. And so it's not about restricting your calcium intake. It's about restricting your salt. Salt becomes calcium in the urine, and that calcium, if it's too high or saturated, it becomes calcium oxalate, calcium dihydrate, what these minerals are made of in the stones. So you need to decrease the salty intake, whether it's you add the salt, but most people, they're not adding salt. They're just eating canned, frozen, they're eating out, and all that food that is frozen or canned or packaged, it is loaded with salt. If you look at the label, the sodium, which is the salt, is very, very high. And when you go out to eat outside, I'm not saying never to do it, but if you constantly eat outside at the restaurant, it tastes delicious because it's full of salt. So you don't have control of the salt, and you don't have to add anymore. It's just filled with it. So salty foods are going to cause kidney stones. Being dehydrated are going to cause kidney stones. And, excess vitamin C and D. Like if you have a deficiency of vitamin D, which most people do, yes, you want to replenish your vitamin D. But many times people come in with these multivitamins that have 100 vitamins, and one of them is vitamin C, which has about 300% most of the time of vitamin C. And every day you're eating food that sometimes can be fortified with vitamin C, and it's just food. So unless you live in Ethiopia or some place that doesn't have access to food, fresh food every day, you don't need multivitamins. It makes your expensive urine and actually going to cause kidney stones. Very few vitamins, yes, you may want to supplement, but the majority you really do not need. So eliminate all these extra vitamins you may not need, especially, again, the vitamin C. Short term, of course, if you're getting a cold and things like that, or zinc, that's okay. But for long term, forever, that's going to just, you're going to become a patient. So avoid that excess stuff, less salty foods, fresh food. So it all goes together with, people that do like a kidney stone healthy diet, they actually lose weight, start becoming not diabetic anymore. Their diabetes goes away. Their blood pressure goes away. Why? Because salty foods are going to increase your blood pressure, right? And so blood pressure, again, salty, that becomes calcium. So it all goes related. Healthy, fresh diets and low in oxalate. And that's something you can look up, online, like high oxalate foods. What is that? Well, there's many, and you don't have to eliminate everything, but things that have oxalate, usually they are healthy foods, but they are not good if you make stones. That would be things like potatoes, which again, people eat potato chips all day, right? They're salty, and there's potato, which has oxalate. Potatoes, nuts. Nuts are very healthy, but if you go to Costco and buy those salted nuts, it's full of salt and oxalate. Hello, you're going to get kidney stones. So even some of the berries, some of the spinach, again, moderation. You can't eat like these shakes and blends and smoothies full of, spinach every single day, and then you will get kidney stones. What can you do to prevent it? Well, eliminate some of these things that I'm talking about, salty, red meat, or oxalate foods. increase your water intake. You gotta be peeing, not drinking, 2 to 3 liters per day. That's a lot, but it's how much you need to dilute out. And things that will prevent them that are natural are oranges and lemons. So if you can tolerate it because of sugar, or you don't have reflux, then you gotta add about 4 ounces per day, whether you put in your water and dilute it, or fresh fruit, which will also have fiber and help you, poop and all that. So every single day, 4 ounces. If you do make kidney stones, you got to be doing that every single day for prevention.
Excellent. Thank you so much for pointing out this important point. I want to say it again, and I want you to say it again. Kidney stones are not going to be prevented if you eat less calcium. You talked about, when someone has a kidney stone, young people, men and women. I ran into years ago a woman in her 20s who had kidney stones, and she had it tested. As you mentioned, having the type of stone tested, so you know what type it is, you can figure out what the issues are. And she said, well, it was calcium oxalate or calcium something. She couldn't remember the actual term, but all she remembered was calcium. And she said, so I'm going to eat less calcium. And my blood ran cold. My heart stopped. I thought, oh my gosh. So thank you. It's less salt, not less calcium, for protecting yourself from kidney stones.
And another thing that actually can lower your calcium, apart from not eating the oxalate foods, the oxalate, if you eat things that have probiotics and calcium, that lowers your oxalate. And an excellent source would be yogurt, because it has calcium and probiotics. So eating that is going to lower your oxalate through the intestine. But that's a great way to, again, not restrict your calcium. You need the calcium. Many patients that have very high oxalate in the urine, what I prescribe is calcium tablets, because the calcium tablets is going to get rid of that oxalate. So do not restrict your calcium. Please eat like yogurt and milk. Please continue to do that, because then they move to like almond milk, and then that's full of like nuts and oxalate. So don't restrict your calcium. That's a great point. Yes, absolutely.
Thank you so much for that. And so there's something also that's really confusing for not just lay people, not just, men and women just walking around and just doing their thing, living life, right? But for physicians, the controversy about how to screen for prostate cancer. That's something that we've been going back and forth about for 20, 30 years now. Can you talk about now what the current recommendation is for men to screen for prostate cancer?
Yes. That definitely has changed. When I was a resident and what it is now, it's been very different when you start, when you end, what to do, and this. So absolutely, it's, trying to keep track of all of it can be a challenge for any physician that has to think about every single organ that we got to screen for, because it changes.
Yes.
So for prostate cancer right now, the recommendations by the guidelines are, if you're 55 years old, that's when you should start screening. So how do you start screening? Well, your prostate, first of all, is an organ that is inside your body. You cannot yourself touch it or feel it. It's inside, like kind of where you sit on the bike. It's really right, above that. That's where it is internally. So you can't feel it, see it at all. And prostate cancer, many times it's asymptomatic, has no symptoms at all. So you're not going to know that you have something wrong with your prostate or prostate cancer, because it doesn't give you symptoms unless it's very, very advanced and all over your body. So prostate can get large, and that itself will cause symptoms. And then at the same time, it's common to have prostate cancer as you get older. So you can definitely have both. And most of the time, the symptoms are from a large prostate, which can cause your flow of the urine to be weaker, or frequency or urgency, and again, not have anything to do with cancer. So you may not have any symptoms, but at 55, you've got to get a blood test called the PSA, prostate specific antigen. It is non-fasting. You do it anytime. Once a year, you check that. And once a year as well, your physician has to check your prostate. They have to put their finger inside the rectum where you poop and just quickly feel for any abnormalities, something that feels firm or lumpy, or we'll call a nodule. If that is felt and your PSA is high, you need to see a urologist. There is no quote unquote normal number. If you look at the blood test, it'll say 4. Below 4, you're fine. And that's not true. I have many patients that have PSA less than 4 that have cancer. And I have many patients that have PSA of 10 and don't have cancer. So it's not a number like blood pressure or diabetes that at a certain cutoff you have cancer. It is looking at the trend, what was it, what is it today, what is your exam, what is your family history? Because a family history of your father or brother having prostate cancer raises your risk, and of being African American. So if you have those things, you're higher risk, and screening probably should start definitely sooner than that. So you have to talk
At
to your
what age,
physician.
Dr. Londoño, would you recommend men of African descent and men with a family history of prostate cancer?
Yeah, it's shared like decision, but let's say like your father, got diagnosed at like, 60. I mean, I would just probably do it 5 years younger even than the 55. I'd probably just start 50, depending. So you kind of have to talk about it, but it's not unreasonable to start 5 years earlier if you have those risk factors. So again, we got to talk about it, but for sure for everybody else, 55, once a year blood test exam, and that's all it is, just once a year to check. And if there is a change, if it goes up quickly, then you want to see a urologist, because then they can tell you, okay, yeah, the risk of cancer is high enough, then we would recommend a biopsy to get some samples and figure out if cancer is present. That is the only way to know if cancer is present, do a biopsy. So it's just like if you had a mole and looked suspicious, you got to take out the mole to see if there's cancer there. The same thing with prostate, suspicion, you got to take some samples. And that can be done in the office, a biopsy. It's very quick. It's mostly really painless, but there can be some discomfort, but it's really important because most prostate cancer, if screened, can be found early and is treatable. And many of prostate cancer we find can be just done active surveillance, which means we just monitor without doing any treatment at all, because you may die with it and not of it. But we're trying to find that aggressive cancer that may change your lifespan, that may give you symptoms. And that's the one we want to catch early and take care of, and not wait till, spread all over your body, because we never screen for it. So easy, just blood test and exam real quick, really will save lives.
I want to talk about one big thing that's been a pushback for me every time I recommended that a patient starts getting annual prostate screening exams or the blood test, the PSA every year. The pushback I would get, though, is, hey, you know what? They would refuse, just outright refuse. They say, I'd rather die than have a rectal exam or have a actual, what they call a manual, or that you described earlier, exam. If you put your finger into the rectum to check and feel the prostate. And so I would say to them, look, okay, you know what? Your loved ones, we don't want you to die, but at least get the PSA. What do you think about that? If they're just refusing, they're saying, I'd rather die, just frankly, I'd rather die. What about just getting the PSA?
Yeah, I mean, first of all, I would say, like, why? I mean, let's dig deeper into this fear. Again, there's always a fear, right? Like,
right.
Are you afraid that it's a man who's going to go away? I mean, what is a fear? Let's really dissect it a little bit more. And then let's try to, discuss it and alleviate the fears. And then, one good news I always tell my patients, of course, they may differ if you're a man, but I'm like, yeah, I'm a woman and I have small fingers. So this is the good news today, that I have small fingers. I mean, they kind of joke about it, but it's really important. I mean, it really takes 2 seconds, and it's so important, because if we feel something, then that's like right away, we gotta, again, send you to the urologist, and you may not feel anything. And I understand what they say about I'd rather just die. Let me tell you, it's not a pleasant death. You can say that now, but
that's right.
It bleeds. Nobody wants to be bleeding when they pee and have catheters, which are uncomfortable. And, when it goes all over the body, you have back pain, you can get paralyzed. I mean, I understand, yes, you say today you'd rather die, but when it comes to it, I really think you're gonna regret that decision. But it is your decision. You have your autonomy to decide how you want to die. But let's just think about it a little more. But yeah, if that's all they agree to, that's all they agree to. You're just getting half of the information. But yeah, we can just follow with PSA only. I mean, that is true. I mean, that's likely what is happening in the community, right? They're just getting PSAs. Nobody has ever checked with their finger, but it's really kind of important to know. And yeah, it's not lovely, but neither is a mammogram. When they squeeze your breast, with a machine, it's really uncomfortable, but it has to get done, because I don't want to die of breast cancer. So it just is what it is. And that pap smear is not super comfortable, but it has to get done. So, I understand the reservation, but the alternative of dying with the symptoms and having the symptoms is actually less pleasant than 2 seconds in an exam really quick.
Yeah. I tell them, well, do you think that women like pelvic exams? Do you think we do this for fun, for kicks and giggles? Yeah, we don't like it either.
Yeah, it's not fun. Like I said, the pap smear is not pleasant. It's uncomfortable. I don't look forward to it, but I gotta get it done. And neither is the dentist, but it has to get done. And my teeth have to be
Exactly.
clean. I
Exactly.
really dislike the dentist, even though I love my dentist, she's amazing. But I have to go and I have to get my
Yeah.
teeth clean. I have to get my checkups, and it just has to get done. So, we have to address why truly, and let's be a little bit more, like look at the big picture and really the consequences of saying no or yes. And it's just a little more information for your benefit. It's not my benefit to put my finger in your butt. It really isn't.
I am not enjoying this. This is not, I don't enjoy this.
I don't either. As a
Zero
urologist,
pleasure
believe me.
out of this. This
Yeah,
does
there's
not,
no
this
pleasure
does not turn
except-
me on.
Yeah, there's no pleasure except the pleasure is I'm helping you, and we can just get it over.
Sure
so
that you stay healthy.
Yeah, you stay healthy. It's for your benefit. Like
Exactly.
I didn't grow up to say I want to put my finger in your butt. That's not my dream, but it's really important. And then the minute that we find something better, believe me, I'll be the first one to say, okay, that's good enough. That was fun. But right now we don't have anything better. And as a urologist, then it helps and guides me to know where to focus my biopsy actually. And many times, really I have magic fingers, but my exam is really accurate about knowing your size of the prostate, and also accurate about like where to focus, and that's where we find cancer, where my finger felt that abnormality and I focus in that area, and then that's where we find it. So really important. Again, I understand hesitation, but we wouldn't do it if it wasn't something that was needed.
Yeah. Thank you for pointing that out. My husband always talks about, he'll come home and I can tell when he's had a doctor appointment with his doctor, who I love because he's so thorough. But when my husband comes home, he says, I really hate my doctor. I'm like, yeah, you had an exam today, didn't you? He's like, yeah, he has fat fingers. I hate him. But he loves him because he's on top of everything and he's saving his life, healthcare maintenance. He's making sure that he lives to fight many, many, many days. So thank you for bringing that up.
Yes.
So I have to ask Dr. Londoño, what does your urologist want you to know?
Yeah, I think we really hit on it. I think, but overall the theme is not just as a urologist, but as a patient, is like advocate for yourself. And I think in some cultures, especially Latino cultures, but in many others, even Asian, we don't ever want to ask. We don't want to, be informed, and we're afraid to ask, and we don't ask anything. Like, why are we on this medication? What is it for? Why are we doing this test? What is happening? And I understand some physicians may sometimes be a little reluctant, or we're pressed for time and we're burned out, so we don't have a lot of apathy and compassion and this and that. But it's really important that you ask, because you have to know what's going on, and it's your health, your knowledge, and it's really important to speak up and ask. So I would say, not as a urologist, but just as any patient, ask, be informed, understand why things are happening. And that is really like a really important thing. And if you find that your physician is not answering, then I kind of would suggest you go to one like your husband, who's thorough, who is really checking up on everything, and who's, just being thorough physician. Really important. That'd be the main thing. And really for women, actually I'm having a webinar today about menopause, really being, on top of the transition, understanding what the transition holds. There is no shame, and painful sex should not be the norm, and recurrent infections is not the norm. It's not something you just live with, and that's just how it is. There are solutions to this. And again, just because perhaps, a penis or baby is not coming in and out, doesn't mean you don't have to have a life that is thriving in your femininity and like the goddess that you are. So just reclaim your power, your femininity, and live, joyfully, really, whether it's in the sexual department or just overall in life.
You said it. You hit it right on the head. It's about life. This is about your life. Ask questions. And the only dumb question is the question that you have in your head that you don't ask. Mm-hmm. And if you're made to feel that it's a dumb question, then to your point, this is your life. Mm-hmm. Maybe move on to find another physician who you can have a conversation with, who you feel that you can communicate with.
Absolutely. Yeah.
Good stuff. Thank you so much, Dr. Londoño. I just can't thank you enough for all you do. This is priceless. It's super helpful. And frankly, I really believe you're going to save someone's life today with this information. This is good stuff.
Yeah, absolutely. It's really important in screening. Get there before the disease start. Live a joyful life with, again, no infections, no pain. And yeah, kidney stones happen to many of us, including myself, a urologist. So because diet or fluids or things like that. So drink lots of water, eat healthy. Not only is it going to prevent the stones, but infections when you drink more water, and it's going to help your diabetes and your blood pressure and all that. So absolutely take, power for your own health, put it in your hands. Don't leave it just to the doctors. Yes, they're going to guide you, but at the end of the day, you got to take control of your health or your diseases and really be an active participant in them. Absolutely.
Thank you so much.
Thank you. It was a pleasure to be here. I really appreciate the time.
Thank you.